Hello and welcome to Scaling Evidence-Based Treatments for Children, Lessons Learned in Connecticut. This webinar is brought to you by the Substance Abuse and Mental Health Services Administration's New England Mental Health Technology Transfer Center, or MHTTC. My name is Valerie Gold and I'm a Senior Advisor with the MHTTC. Before we begin, I'd like to go over a few quick housekeeping items with you, and as I'm doing so, please keep going in the chat box. We really want to see who's here. And we're grateful for all of you that are starting to fill out the poll we have up in the room around your role. Today's webinar will run for 1 hour and it is being recorded. We will spend about 40 to 45 minutes listening to our amazing presenter, Dr. Jason Lang, and then we will reserve the last 15 or 20 minutes of our time together for a question and answer session. Participant microphones will be muted throughout today's event. If you're calling in using your phone, please be sure that you're also muting your computer speakers, as that will help with minimizing the background noise. If you have questions, which I hope you will, during the presentation, please go ahead and enter them into the chat and questions box. We'll be pulling those out and then sharing those during the Q&A session at the end of today's event. Let's see, what else do I need to tell you? I think that is it. If you have questions after the webinar, of course, you will email us, and we'll also be sending you a follow-up email after the event with a link to the recording and information about CEUs for those of you who will need those. The New England MHTTC is led by Yale's Program for Recovery and Community Health, in partnership with C4 Innovations and Harvard University's Department of Psychiatry. Our mission is to use evidence-based means to disseminate evidence-based practices across New England and beyond, and our area of focus is recovery-oriented practices, including recovery support services. Our MHTTC is committed to equity, inclusion, and responsiveness to the needs of the communities we serve. To ensure the responsiveness of our work, we actively develop and maintain a network of government officials, policymakers, system leaders, administrators, and community stakeholders, providers, researchers, youth and young adults with lived experiences, and faculty members and family members from each of the 6 New England states to guide our activities. We would love to know who's joining us and who's calling in today, so if you have not already introduced yourself in the chat, please go ahead and do so. And today, it is my honor to introduce our presenter, Dr. Jason Lang, who's the Vice President for Mental Health Initiatives at the Child Health and Development Institute of Connecticut. Dr. Lang is a clinical psychologist and a nationally recognized expert in child trauma, evidence-based practice, and implementation science. We are delighted to have him with us today. Jason?
All right, thank you. Can you hear me?
You sound great.
All right, good. Thank you, Valerie, and thank you for the invitation to speak today. And thank you, all of you on the call, for taking the time in these unprecedented times. I am here in my bedroom live, and look forward to sharing some information about Connecticut's lessons learned with evidence-based treatments for children with mental health conditions. I also want to acknowledge up front that the work that I'm talking about today is really the product of dozens and dozens of different people. And I'm honored to be able to recognize or to speak on behalf of all of this work, but there's many people at CHDI and in Connecticut that have contributed to this work. I am from the Child Health and Development Institute, and we are an independent agency that's a little bit kind of an unusual type of organization, and we work really to improve the health and mental health of all children in Connecticut by working across policy, systems, and practices. And I'm going to say a little bit more about what we do further on in the presentation. Most of what I'm going to talk about is really about Connecticut's experience over the past 13, 14 years implementing evidence-based treatments for children. The recent pandemic has really obviously changed the world and changed much of what we do over the past 6 weeks. So we're really just beginning to figure out how to adapt and in light of the new world. So I will perhaps touch a little bit on that, but most of what I'm talking about is not related to the pandemic. So I am going to talk about how Connecticut has disseminated evidence-based treatments, some of the outcomes that we've seen, and really touch on some of the implementation and policy challenges and strategies that we've tried to address those challenges over the past 13 or 14 years. I think many people are now familiar with this notion of a research practice gap, and that is the idea that we have many, many great evidence-based treatments, interventions, prevention programs that have been developed and rigorously tested, published in the academic literature, often with randomized trials and other real solid evidence. Yet most mental health services for children, and I think it's also true of adults, that are provided in the community and in schools are not evidence-based treatments. And this is not a newly recognized problem. The Surgeon General more than 20 years ago reported this, but it continues to be really a perplexing challenge to figure out how to bring these evidence-based treatments into practice so that children and families can benefit. We know that it takes many years to put a evidence-based treatment into practice, that most research actually isn't put into practice at all, and if it is, it takes about 17 years for an evidence-based treatment to be fully adopted. This one estimate of 9 years, and we don't really know what percentage of children are getting an evidence-based treatment nationally, but the best estimates suggest that it's very, very low, 1 to 3% from this article from Eric Blooms a few years ago. There are a number of reasons why evidence-based treatments are a challenge to bring into the community, and I want to use this example of hand washing, which I actually have used for a number of years, but I think it's especially timely now. And hand washing is an evidence-based practice for reducing the spread of infection. And pre-COVID-19 and before all of this happened, there were estimated to be 100,000 deaths annually in the United States alone due to hospital-acquired infections with significant costs, and worldwide much, much higher than that. And this has been a recognized problem, and it's also been recognized that hand washing is probably the most basic approach to reducing hospital-acquired infection. Or it's one of the significant ones. So the World Health Organization a number of years ago looked at this. They found an average compliance rate of about 50% when medical professionals should be washing their hands. They did it properly. And then put together a large initiative to improve hand washing. And anybody want to guess how many pages their hand washing guidelines were? You want to type it in the chat box quickly? Just a wild guess. I see somebody's, all right, 15,500. Well, 59, 1. All right. Usually I get on the lower end. Yeah, most of those are on the lower end, pretty consistent. The answer is actually 270 pages, the World Health Guidelines for hand washing. And, hand washing is a pretty simple thing, but when you really dive into it, there are a number of complex issues that need to be addressed, and things like different bacteria or viruses need different soaps or detergents or sanitizers. Where do you put the sanitizers in the sinks in a hospital? How do you deal with raw skin from people washing their hands too much? And then there are cultural issues around hand washing that need to be addressed in different populations. So all that to say that the World Health Organization made this big campaign, this very complex document, and they did successfully improve the rate of hand washing to about 2/3 of the time. I use this as an example because I think hand washing is about as simple of an intervention as you could develop, but implementing it successfully takes a lot of thought and work. And so when we talk about the type of intervention, a behavioral health intervention, which often involves multiple sessions with children, with their caregivers, sometimes together, a structured approach that usually has a big, thick treatment manual, and then you add that to very diverse communities, clinicians with very different training and background, agencies that may have different policies for providing treatments, reimbursement issues, and you start to see why implementing an evidence-based treatment successfully is challenging. In terms of outpatient children's behavioral health, and that's most of what I'm talking about today, we know that roughly 20% of youth will have a mental illness. Most of those youth do not receive treatment or don't receive timely treatment. We also know there are big disparities in access to mental health treatment and outcomes, such that children of color often have poor access to mental health services, typically don't engage in as much mental health treatment and have poorer outcomes when they do engage than white children, and this has been a pretty consistent pattern. And then we also know that mental health treatment is only marginally or moderately effective. About half of kids who get mental health treatment show improvement, based on best estimates. And evidence-based treatments are really a strategy to try to improve that that rate of improvement, and that's what they have. They've been developed and tested to work better than usual care. I did mention the low rate of evidence-based treatments, which is the problem we're talking about. So a little bit of context in Connecticut. Connecticut is one of just a few states where children's mental health is incorporated into a consolidated state agency with child protection as well as prevention. In many states, behavioral health for children falls under the adult behavioral health system. And so there are some benefits to that in Connecticut as well as some challenges, but that's the way that we operate. So in Connecticut, our state agency, the Department of Children and Families, funds a range of children's behavioral health services across many levels of care, including outpatient, extended day treatment, mobile crisis services, in-home services, and historically has had a big focus on evidence-based treatments across those different settings. Connecticut also does a lot with quality assurance, quality improvement, which is very consistent with our approach to disseminating evidence-based treatments. There's a state requirement for results-based accountability in Connecticut, and so all grant-funded programs report on their outcomes. And then finally, Connecticut has quite a long history of being pretty progressive in terms of trauma-informed care, both with children's mental health and in child-serving systems as well as in our adult-serving systems. One kind of piece that makes Connecticut a little bit different than many states is that we have been under a federal consent decree since 1989, or the State Department of Children and Families, which was largely tied to concerns about meeting the needs of children in the child welfare system. And that consent decree has kind of continued to be something that every administrator and governor has tried to get out of. And one of the challenges to that has been meeting benchmarks around children's mental health needs for children in the child welfare system. So some of the early work around evidence-based treatments in Connecticut and nationally was really moving kids from congregate care settings to back to the community. And Connecticut invested around 2000 and continues to do so in-home evidence-based treatments. But it wasn't until about 2007 that they started looking at outpatient care. And outpatient care is where the most children are seen for mental health treatment in Connecticut. Many more are served there than in in-home settings or congregate care settings. So what I'm going to start with is our initial outpatient evidence-based treatment, which is trauma-focused CBT. I think it's one many people are familiar with because it's been disseminated nationally for quite a few years. And back in 2007, Connecticut selected TFCBT as the initial outpatient treatment, really based on that recognition of childhood trauma being a big, much more common than people had realized, and it was also a treatment that had quite a bit of empirical support and was also being disseminated nationally through the National Child Traumatic Stress Network, which is a SAMHSA-funded network. And so the state, basically said, we want to make this treatment available to children. We want to make sure that it's working in Connecticut, and we want to make sure it's sustainable. I think back then especially, this was really kind of almost unheard of, is they turned to look for an intermediary organization to help disseminate TFCBT. And that is an organization like the one I'm at, CHDI, that really works in tandem and in collaboration with the treatment developers and researchers, the state systems, consumer advocates and family members, and community mental health providers and schools to think about how to put evidence-based treatments into practice in a sustainable way, given the constraints and the policies and the reimbursement issues present in Connecticut. There have been a couple of reports on these intermediary organizations, which I show on the slide here from MacArthur and Annie Casey, that kind of highlight what they are. Initially, I think the other kind of innovative thing that Connecticut decided to do was to use the Learning Collaborative Breakthrough Series Collaborative model back in 2007 when there weren't very many people doing it. Again, the SAMHSA National Child Traumatic Stress Network was just beginning to use this, and so Connecticut brought this model through the help of some folks that were connected to NCTSN to use as a statewide dissemination approach. And the Breakthrough Series or Learning Collaborative is quite different than the traditional, send clinicians to a 2-day or 3-day training. It's really an intensive year-long effort where a team of folks, clinicians, clinical supervisors, agency administrators, get together and work internally in their agency and with other teams across the state to figure out how to implement the model in their communities. And so we did these 3 learning collaboratives or Breakthrough Series collaboratives with the state from 2007 to 2010. And one of the big ways that a learning collaborative is different is there was really a big focus on quality improvement and the use of data and metrics. And so from the beginning, and we continue to do this now with all the treatments that we disseminate, we require agencies and clinicians to report on some data at the child and family level. And we're very careful about requiring as little data as possible. And so we look for measures that have good psychometrics, that are free in most cases or very, very cheap, because we found that sustaining measures that are pay per use was just not really feasible. We use the briefest measures we can, even if they may not be, the most robust, or just because some of the feedback we've gotten along the way is that doing longer measures with, every child that a clinician sees becomes very burdensome. The other thing is that we really look for measures that are clinically useful. And so for trauma-focused CBT, for example, a trauma treatment, we use a PTSD symptom scale, and we train clinicians as part of their delivery of TFCBT, how do you use this measure clinically, both to assess children at baseline, determine their appropriateness for the treatment, but then also how to periodically reassess and understand if treatment is working. Clinicians are trained to share the results with families, and it also allows the state and us at CHDI to kind of continuously monitor how many kids are being served and how children are doing with treatment. On the right side, you see some other examples of measures that we've used along the way. All of those those are freely available. With the data that we collect and that the agencies provide, we do a couple of things. One is we provide monthly dashboard reports like you see here, and the gist of this is really just to give a high-level snapshot of how many children are receiving a treatment, maybe some basic fidelity indicators. So for TFCBT, it may be how often are caregivers involved in their child's treatment sessions, which is a big part of TFCBT. We also report on completion rate of treatment and other indicators that are kind of varied by the model. And then agencies get this data back monthly and use it to work on QI plans for continuing to improve their implementation and to support their implementation of the model. On the right side is a snapshot of a child-level outcome assessment looking at, I believe it's PTSD symptoms over time based on the child report and the caregiver report. And the clinicians are trained to use this data, again, to inform their treatment planning and also to share the results with the family. So based on these initial 3 TFCBT learning collaboratives, we kind of looked at the data and found, the gist of it is we found that children were doing much better. Their post-traumatic stress and depression symptoms were much lower at discharge. There's a paper describing this initiative, but I think the key was that the providers and the clinicians that were trained really liked it, and they felt like it provided some structure and that their children and families were doing much better. So as this ended, right around the same time, Connecticut was the recipient of a federal grant to really to promote a more trauma-informed child welfare system. I'm not going to say much about the rest of that grant, but I will say that part of it, a small component of that grant, was to disseminate some more treatments for children, specifically in the child welfare system. And we disseminated trauma-focused CBT, and we disseminated another model from Yale Child Study Center called CFTSI. In those learning collaboratives, one of the things that, one of the things that we did differently was, because this was geared toward child welfare, we didn't just train clinicians. We trained teams of clinicians and their local child welfare staff to make TFCBT available. And this was very interesting because I remember some of the initial meetings with a local team of their behavioral health providers and their child welfare staff, and went out and sat with them around the table, and all the clinicians were on one side and the child welfare staff were on the other. And there was often some bad blood between them because the clinician would say the child welfare folks never returned their calls and didn't get information back, and then the child welfare workers would say the same thing about the clinicians. And so this kind of cross-system learning collaborative forced them to work together in a team for a year and to better understand the constraints of each other's system. The clinicians were trained in TFCBT, but the child welfare staff were trained to screen and identify children who were experiencing trauma and could benefit from TFCBT. And then they were both trained in how to better coordinate care for those kids across the 2 systems. Another kind of similar model, which really extends this even further, is the community-based learning collaborative from South Carolina, Rochelle Hansen and Ben Saunders. And they bring together clinicians with what they call brokers, all brokers of children's mental health services, including child welfare, juvenile justice, GALs, schools, pediatric providers, and they do a year-long learning collaborative to improve identification of children who might benefit from TFCBT across those different systems. So Connecticut, one way that Connecticut was, profoundly impacted was the Newtown tragedy in 2012. And Of course, that was felt not only in Connecticut, but also nationally and across the world. And a number of policy and legislative changes happened after Newtown. The one that I want to touch on briefly is that the legislature required a state children's behavioral health plan, partly in response to the findings from the Newtown reports and some of the identified gaps in mental health services that I think had not really been a secret, but now were really coming to the forefront. And so that plan, which is publicly available on the website, planforchildren.org, outlined a roadmap for behavioral health broadly in the state, including evidence-based treatments, as well as trauma-informed services. And then the legislature also provided some additional funding to disseminate some more evidence-based treatments, and that included the MATCH EBTC model and CBITS and Bounce Back, which are the school-based group models. In addition to that state funding, Connecticut also, or EBTs, together with Connecticut, were the benefit of a SAMHSA grant to disseminate several more models. And so as we kind of got to this point where there were 5 or 6 different models that were being disseminated, we started to put together, think about how do we kind of do this with different models that have different requirements, some different settings. And that's where we kind of landed on this dissemination support center model, which I'm going to spend a little time just kind of talking about what this looks like, because this is kind of the heart of what we do now across different evidence-based treatments. And so we continue to use learning collaboratives or breakthrough series collaboratives for that initial implementation or initial dissemination of a model, where we need to do the beginning training for a new agency in a new model. And we find that that intensive year-long process really has been very successful in resulting in sustained implementation. And when we've tried to do more traditional 2 or 3 day trainings only, or trainings plus some consultation, at least for new agencies, that has been much more difficult to sustain. We also we have a pretty rigorous selection process. So we don't just train any agency or clinician that wants, to do TFCBT or MATCH. We train agencies that are really committed to understand what it takes. And what it takes is not just the clinical training, but also the commitment to changing their policies and procedures, to screening and triage processes, to freeing clinicians up to do the evidence-based treatments, to reporting on the data and using standardized measures. And so we have a formal contract with these agencies. They submit data, and then in turn, through state and federal funding, we provide them all of the training and consultation in the models. And that includes the clinical training and consultation, but it also includes what we call implementation consultation. And so, we use those monthly or quarterly reports. We typically go out and meet in person pre-COVID-19 with each agency and review their progress and status and identify quality improvement strategies. I think one of the things that has helped make this successful is that we have a relatively modest pool of funding that we provide to providers based on performance. And so, based on the number of children they see and the outcomes they get and the number of clinicians that they train, they each get a check twice a year, these agencies, to help offset some of the lost revenue that it takes to implement an evidence-based treatment. And that really evolved over time because we started to realize, and the agencies told us very clearly, that providing evidence-based treatment does take more time and money than providing usual care. And we actually worked with the providers on a couple of cost studies a few years ago to document that. And that additional cost is really paired with the same reimbursement rate for mental health services, no matter what they're providing, makes it a real challenge for providers to sustain and expand evidence-based treatment. A couple other things I want to touch on this graphic are the credentialing and certification. So we, for each of the models, we have a credential or certification that clinicians can get based on completing all the training requirements as well as completing a certain number of successful cases. Sometimes the models have national certification and others don't, but we do that to give them some recognition of their work. The cross-system collaboration is really about moving beyond clinical and behavioral health providers to all of the other, as I said before, brokers that refer kids for mental health services, and training them to understand where evidence-based treatments are available, how to access them, what the benefits of them are. I think many people don't realize that, you refer a kid for mental health treatment and what happens in that session can vary tremendously. And so we continue to try to do that as much as possible. And then we've also held an annual conference for all of the providers that we train to give some additional clinical expertise. And the conference is largely put on by the providers that we train. So many of them share their innovations and successes with these models with each other. I'm going to shift to some of the outcomes. So, because we do require the data to be collected by clinicians and agencies, we can look over time and, in a given year, how many kids are getting served. And so the graph on the left is just a count of how many kids in Connecticut got one of these evidence-based treatments that we're involved in disseminating. And to be clear, there are other evidence-based treatments, especially in-home models, that are not included here because we're not involved in. But you can see that the numbers increase over time. The slide on the right is a population heat map of Connecticut. And let me see if this works. So, if I go back and forth, this is where the centers of population are in the red and orange. And then these orange dots are the clinic sites where evidence-based treatments are provided. And so they just kind of naturally match on to the areas where there are greatest populations. And you can see that there are some places in the state that are a little bit more rural in the Northeast and Northwest, especially that don't have a lot of access, but those are quite rural areas. But for the most part, the populated areas are covered. So for me, one of the, probably the main point of all this is that we want children to get better when they have a mental health problem. And we want to support their we want to support their recovery, the reduction in symptoms, and we want to do that. We want to be able to show that evidence-based treatments do that at all, and that they do that better than usual care. And so these data here are from trauma-focused CBT, more than 2,000 kids that have gotten it. And it shows the gray bars where they were at baseline on measures of PTSD. The red line is the likely cutoff for a diagnosis of PTSD. So you can see prior to treatment, on average, most of those kids fell well above the diagnosis, and probably many of them had a diagnosis of PTSD. And then post-treatment, the blue bars show their symptom levels, which are, much reduced and well below the cutoff for likely PTSD. So, this is nice to see, of course, and I think it's also helpful for the clinicians and the agencies to see, as well as the state, to know that that children are getting better. The next question that we have been interested in is looking at usual care compared to evidence-based treatments. And we've been doing this with administrative data from Connecticut that covers about 25,000 children a year who are seen at outpatient providers that our state contracts with and funds. So it's not every child in Connecticut, but it's a pretty large pool of kids getting outpatient treatment. And we know what types of treatment the clinicians are reporting. And so in this slide, you see the kids that are getting no evidence-based treatment at all on the right. On average, they are showing improvements around 4 points or so on an outcome measure. When you look at the other evidence-based treatments, especially MATCH and TFCBT, the rate of improvement overall is much higher. It's also higher for any of the EBTs. We look at other EBTs too that are that we're not as heavily and actively disseminating, but some clinicians are trained in other models as well. On the next slide, I think one of the things that we've kind of found fairly recently is that the evidence-based treatments appear to reduce those disparities in outcomes that I mentioned at the beginning. And this was not really it's not how EBTs are advertised. It's not a benefit that I've seen people talk about. But when we look at the difference in this case for Black and Latinx children on the no EBT graph, there is a small disparity such that white children get a little bit better outcomes, and that's consistent with the general literature. But when we look at TFCBT and MATCH specifically, that disparity is actually reversed, and we're finding better outcomes for the Black and Latinx children. But regardless, all those children are getting much better outcomes when they get TFCBT or MATCH. The last kind of few things that I'd like to talk about are this, as we kind of have gotten a number of different evidence-based treatments up and running, I shared with you the good news in terms of outcomes and kids getting treatment. I think one of our challenges has been that, still evidence-based treatments are not majority of kids are not getting evidence-based treatments. We estimated that now it's probably somewhere between 20 and 25 or 30% of kids in Connecticut are getting, in these clinics, are getting an evidence-based treatment, which is, a big improvement, but, still the majority are not. And so we've been working with the state for the past year to look into the 25,000 kids a year who are getting outpatient treatment and to try to identify ways that we can improve outcomes for those kids, both with evidence-based treatments and also perhaps applying some of the lessons learned from evidence-based treatments to the broader population. So maybe some targeted trainings, some new evidence-based treatments, and use of data and QI strategies. In addition, there are some other evidence-based treatments we're now kind of rolling out through the SAMHSA grants. And of course, the Family First Prevention Services Act is a new, a relatively new federal opportunity for states to get federal funding for evidence-based treatments to prevent children from involvement in the child welfare system. And so Connecticut is in the process of figuring out our plan for that, and I think that's going to have some big implications for evidence-based treatments, and especially getting some funding from the federal government moving forward. I want to talk a little bit about some facilitators for us and some of the things that we have identified as helping along the way. I think first, certainly the commitment in Connecticut from state agency leaders, even from the governor and the legislature around children's mental health has been huge. And Connecticut has been plagued by budget problems for many years. I know the pandemic is going to make this probably worse for everybody in the next several years at least. But we've had, a real strong commitment to this, which I don't know how you really scale this up without that. I think the intermediary organization role has been very helpful to bring together often different partners who all, may have the same goal in mind, but come from very different perspectives, and that's the state agency people, the researchers and treatment developers, consumers and family advocates, and the community mental health providers. IHI has the triple aim, and I have the triple M, which is minimal meaningful metrics, and really making sure that we build in some data so that we can know what's working and what's not, but really making it as minimal as possible. And I think this is where our partnership with treatment developers and researchers really becomes kind of interesting, because many of them have quite a long list of measures that have been used in the research and that they may want to have collected, but we also recognize that that's not feasible to scale up across the state. So we try to do we actually try to eliminate data whenever we can. We're really trying not to add anything, and we continuously kind of pare back so that we have the minimal amount. I think that the focus on a full implementation package and working with an agency rather than individual clinicians by themselves has been a big part of the success, because this does take a commitment from an agency, beyond just the clinical training. And the agencies really need to say that they're going to support their clinicians to do this, adjust their productivity sometimes, give them the time to attend training and calls, and other things that I've talked about. And then the last one, a collaboration with other systems. So improving knowledge about EBTs, screening for mental health, and really trying to steer those that refer kids for mental health services to the best treatments that we have. Last slide I have is really to just give some ideas about getting started. Again, this was pre-pandemic, and I think much of this still applies, but it is a whole new world, and we need to start thinking differently. But I think one thing is to really start small and gather some proof of success. We started with 6 agencies and maybe 18 or 19 clinicians in our first year, and and then looked at their outcomes. And it was with those outcomes that we were able to, advocate for continued support, and that has kind of continued to grow over time. And then also to recognize when something doesn't work. It's okay to change it, get rid of it, do something new with it, but having the data has been helpful in that way. We've cultivated a lot of champions and partners both from the state, but also from the community mental health agencies that we've trained. And we really try to, one thing that we require is that every agency has a coordinator who's designated to coordinate their agency's team in that EBT. And so many of those champions become their site's project coordinator. Some of them have gone on to become agency trainers in the model, or even in a couple of cases statewide trainers. But we really need that within the agencies. The funding uncertainty certainly has been a continuous challenge, requires flexibility. We have had some years where there was a lot of money, and we're tempted to expand really quickly, and then but you never know where you're going. So I think we've always kind of thought about expanding in a sustainable way, and we've ended up giving a lot of the state funding as performance-based incentives, recognizing that in order to really do this, providers are going to need some support. Developing local capacity. So I think a common challenge with EBPs is that you can't fly in a trainer every time you need to do a new training, and so we've really tried to build capacity for in-state trainers or agency trainers. And some of the models that we've been training in, that's a new thing for them, and so it's one of those things that takes some time and negotiation, and and of course model developers want to know that their models are going to be trained on with fidelity and practice with fidelity. And then the last one is to avoid train and pray. I think we're not, many places have learned this lesson that, if you just hold a big training and invite anybody that wants to come, that very rarely leads to sustainable delivery of an evidence-based treatment. And so, we've kind of made it a package deal where they get all the training and the consultation and the support, but they also have to sign a contract and commit to doing things on their end as well. So I think I will turn things back over to Valerie. Does that sound all right?
That sounds great. Jason, thank you so much for all that you just shared. And now we are ready to begin our Q&A session. Please, if you haven't already, go ahead and enter your questions in the chat box. We're going to get to as many of these as we can with the time remaining. And if we don't get to your question, we'll be happy to follow up with you over email after today's session. So the first question we have for you, Jason, what more can you tell us about Connecticut's experience with sustainable financing for EBTs, including Medicaid reimbursement?
Well, I think the financing has been one of the biggest challenges. So I think, we've learned and demonstrated that it costs more to deliver EBPs. Medicaid and, in Connecticut, every private insurer that I'm aware of pays the same rate no matter what. And so, we have tried to advocate for either getting an enhanced rate or some other way to provide a more sustainable solution to the cost problem. We're now able to demonstrate that the outcomes are better. They're reducing disparities, better mental health outcomes, I'm sure will likely lead to future reductions in costs. That's another thing that we've been thinking about doing is how to look at costs longer term. But we have not gotten an enhanced rate yet, and we continue to say it and advocate for it everywhere we go.
Thank you. And yeah, we all understand that measuring those longer term gains is so elusive but so important. All right, next question up. We have, what can we do to begin this work given the restrictions of the COVID-19 pandemic?
Yeah, so I think, in the last 6 or 8 weeks, obviously everything has been turned on its head. So, a couple of things that we have noticed, one is clearly we're not doing in-person, training anymore, at least right now. So we are shifting to some virtual training, and almost all of the providers now are doing virtual evidence-based treatment delivery. I was actually on a call with all of our providers earlier this week, and one of the really promising things that I heard many of them say were that the virtual delivery, while it took a couple weeks to figure it out, it's working quite well, and that they had a number of families that were transitioning from in-person treatment to virtual, and that has gone well. Families seem to like it for the most part. Clinicians often are, more productive. And it reduces some of the, the travel and logistic barriers that were there. So I think beginning, I guess if you already have some evidence-based treatments, you can certainly make the transition. I think if you're really new to this, then I think starting with bringing people together who have an investment in children's mental health is kind of a place to start. So it might be at the state level, it might be in your local community, but bringing together, state people, local providers, maybe some consumers or family advocates, and really trying to build a consensus or a, consensus that this is a good thing, and then how do we get it started or pay for it? And again, start small, but gather some proof of success.
Thank you. All right, I think we have time for one more question. We know that there is growing interest in the idea of trauma-informed systems for children. How do we think about implementing EBTs together with this idea of trauma-informed systems?
Yeah, so I think that, the idea of trauma-informed systems is really consistent with EBTs, and but it, obviously it's a little bit different. So trauma-informed systems really is looking at any child-serving system or even family-serving system, and how to bring information and best practices to those systems to address childhood trauma. And so in schools and primary care or early childhood settings, one of the things that a trauma-informed system does is try to identify those children and families who are experiencing trauma. It's not that every child needs trauma treatment, and I do want to be real clear about that. Many children are resistant, families are resistant. They may not need mental health treatment, but when they do, and those systems are skilled at identifying those kids who do, it's really about referring them to a provider that has that expertise in evidence-based treatment, evidence-based trauma treatment. And so, in Connecticut, we've done quite a bit of both, trauma-informed and evidence-based treatment, and a lot of it is improving awareness about where you can get evidence-based treatments, the benefits of them, and I would say public awareness is an ongoing struggle. I think most people don't realize, what an evidence-based treatment is and how different mental health services can look depending on where you go.
Thank you, Jason. And I think, actually, we can squeeze in one last question before we go into our sort of closing slides and ask people to take a moment and complete the survey that will pop up when we get there. So a rapid fire last question that will be tough to answer succinctly, but I bet you can. What can we do to improve access to EBTs for children and youth so that they become the new standard of care?
Yeah, I think the policy and reimbursement is really the place that we need to have some success, and we need to figure out how to build either a better rate for evidence-based treatments or a better rate based on outcomes, which would also incentivize evidence-based treatments into Medicaid and other payers' policies, because we know that that they cost more to deliver. I think in addition to the reimbursement, other policies around mental health treatment, I think, should encourage or incentivize evidence-based treatments. And then I think the other one is public awareness, and just trying to do a better job of bring awareness of the benefits of evidence-based treatments to the public. I know for me personally, if my child needed a mental health treatment, I would look at the research, figure out what services were available locally. But I think many people, kind of assume that if you make a referral for mental health, that is going to provide the best quality treatment, and that's not always the case.
Great point. Thank you. Okay, well, this brings us to the conclusion of today's event. Before we wrap up, I want to just share a couple of resources with you. First, we have contact information for Jason if you have questions that you want to follow up directly with him about. Second, some of the resources that he named earlier in his presentation. These are great places for you to learn more about many of the topics that Jason covered in his presentation. So please take some time and take a look at them. And again, we will be sending out and posting the materials from this webinar, so you'll be able to access these links if you're not copying them really quickly. Here's the contact information for the MHTTC. We're always adding great new content and resources to our site, so please visit us often. And we have a whole bunch of upcoming events that may be of interest. This looks really small on the screen, but I can share a couple of the ones that are coming up. On May 12th, we'll have a compassionate school approach to children's mental health. We'll have Courageous Conversations, a partnering tool to achieve equity on May 26th. So take a look, see if you'd like to join us again. We certainly hope that you will. And before you leave the room, please do answer the survey questions that Vanessa's going to have show up on the screen. It should take just a minute, and we really value your feedback. So, Jason, thank you again. This was really, really a wonderful presentation. I know I learned a lot. I'm sure others did as well. And to everybody else, thank you so much for joining us today, and be well and take care.
Thank you.